Hello everybody, Nelson Virgil here with ExcelMale.com and DiscountedLabs.com. I will be talking today about two very important studies about testosterone's effect on the cardiovascular system. One of them is called the TRAVERSE study, that was the one published recently, and the TOM trial from the past. As you all know, I'm an author. I've written two books on hormones, testosterone in particular. So I'm an advocate for the safe use of testosterone replacement therapy. But these two studies actually raised a flag, at least for me, on certain issues that have not been really reviewed by anybody yet. And hopefully this will incite some of the private investigators to do so. So, as I said before, I'm an author, founder of ExcelMale.com and DiscountedLabs.com. So this one was just published on June 16th or so, and the Endocrine Society concluded that men using testosterone replacement do not have an increased risk for cardiovascular events. So that's great news. We've had several studies like this. This is not the first one to conclude this. We had some bad publicity around 2013, 14, around there, where two poorly done studies actually concluded the opposite. But there have been many since then. But this has been one that has been really done with the most severe scientific rigor. And with private investigators that are highly respected. So let's talk a little bit about the TRAVERSE and the TOM trials. I want to talk to you guys about something that we need to think about. I'm not here to scare anybody, but I do think that it is time to talk about little details on these two studies that may not be 100% clear. So this other study called the TOM trial, the Testosterone in Older Men, TOM trial, and this was basically done around 2008 to 2010. It was published basically 13 years ago. Had basically 209 men, very old, 74 years old, with low testosterone, and they had very limited mobility, frail, problems going up and down the stairs, etc., etc. So they had low testosterone and they were put on androgel or a placebo to determine if the therapy increased strength and the ability to walk and climb stairs. But the Data Safety Monitoring Board, this is what the ESMB is called, stopped the treatment phase of the TOM trial in December 31st, 2009, because they had some signals that there were some cardiovascular events that had been elevated in the testosterone arm compared to the placebo arm. So it was halted. This study actually was halted, published in JAMA, a very, very respected scientific journal. And that's when I started scratching my head. Obviously, these are very old men with a lot of issues functionally and physically. So basically and I'm going to speak about the TOM trial a little bit more before I jump into the recently published TRAVERSE study. So the TOM trial, like I said before, a few 200 and some elderly men, low T, most have high blood pressure, 50% were obese, 25% had diabetes. So lots of comorbidities. So high risk, we call this a high risk population. And 6 months of high dose testosterone gel. The high dose really is androgel. I don't even know why they use the word high dose, because it's 1% or 1.62, but I think in this case they use 1%, or placebo for 1 year. So the results were good. I mean, and these are not guys that were working out or going to the gym. They're older, 70-something men, but their leg strength increased with testosterone, chest strength increased, speed of walking upstairs with a load increased. So really good news. I'm kind of we expected that. But they had an increased cardiovascular events with testosterone. 29 in the testosterone arm, and 5 in the placebo arm. We have to be really careful when we say what are cardiovascular events. Cardiovascular events could be obviously a mortal, a fatal one like heart attack, but there are lots of non-fatal cardiovascular events like edema, obviously high blood pressure, being out of breath, high palpitations, worsening of AFIB, etc. So this study really included all of those cardiovascular events. So it was halted, and then obviously, to be honest with you, nobody really talked much about this study, but it was really something that gave me a lot of concern. So as I said before, the events were peripheral edema, water retention, on the extremities and the ankles, mostly hypertension, arrhythmias, and syncopes. So they included everything else, okay? So some people had heart attacks, but the most significant cardiovascular events were this. And these events were significantly elevated in the testosterone group, even after adjustments for baseline risk factors, such as high cholesterol, low HDL, high blood pressure, and diabetes. And this negative effect was maintained to 6 months and did not diminish after post-treatment follow-up. So that's very concerning. So this other one, which was involving a lot of the top names in testosterone replacement, endocrinology, etc., was just recently published in 2023, the TRAVERSE study, the trial, cardiovascular safety of testosterone replacement therapy. Once again, older men in this case, to evaluate the effects of testosterone replacement therapy on the incidence of major adverse cardiovascular events, they call that MACE, and efficacy measures in hypogonadal men. Inclusion, men between 45 years of age and 80, with low testosterone, less than 300 nanograms per deciliter, who exhibited at least one symptom of low testosterone and have evidence of cardiovascular disease. So these are guys between 45 and 80, a little younger than the previous TOM trial, but they had to have low testosterone and evidence of cardiovascular disease. So these are also high risk. I mean, these studies were done, and more power to them, to these investigators, in high-risk patients, because that's really what most the FDA is concerned about, and most of the criticism from previous studies have been that men were not old enough and they didn't have a lot of comorbidities. So here's another group, a little younger than before, but you can be even 80 years old and join the study. So the primary outcome was to, the composite death from cardiovascular causes or non-fatal myocardial infarction. You had a heart attack but you survived, and non-fatal stroke. You had a stroke but you survived. So there was basically, this is a placebo arm, and there were 2,600 men on the androgel, another androgel study, 1.62%. Okay, so there was hardly any difference in this one, 7 and 7.3 here. When it comes to the secondary outcomes, there was a signal, a little bit of a signal on kidney injury percent. To be honest with you, I've gone through the data. This is hard to explain. They will have another analysis of the data. It's mostly creatinine increases, whether or not it was because more lean mass accrual, which can increase creatinine. So this is not clearly explained. However, what really was significant, and on a P of 0.001, this is a significant p-value, was the 5.2 versus a 3.3 non-fatal arrhythmias warranting intervention. So arrhythmias, palpitations, people that had worsening AFib symptoms were significant. Okay, so conclusion: in men with hypogonadism and pre-existing or a high risk of cardiovascular disease, testosterone replacement therapy was non-inferior to placebo with respect to the incidence of major adverse adverse cardiac events. So, the conclusion was testosterone is as safe as placebo. But this really was not addressed. And I think the private investigators are gathering some more detailed data on this issue, and also on the kidney side, because testosterone has been found safe on kidneys and liver and all that, unless you take a methyl testosterone orally. So anyways, so the Traverse trial, I took this from my urologist and one of the best urologists in the country, Mohit Kara, here in Houston at Baylor. I borrowed this from him. The study design was basically testosterone versus placebo, 1-to-1 ratio, 1.62 is the new formulation of androgel. They drew blood 2, 4, 12, 26 weeks, and month 12, 18, 24, 36, and 48. They follow people up to 48 months. So that's a long-term observation. And the titration of the androgel was automated by algorithm to maintain a testosterone level between 350 and 750. So these guys never reached levels above 750. And hematocrit, HCT's hematocrit, blood viscosity, the amount of red blood cells in the serum, was they kept it at under 54% by titrating the dose. The study does not show whether some of these guys had to go for therapeutic phlebotomy or blood donations. So that's something I'm going to have, by the way, an interview with Dr. Kara in September to talk about this study. But I decided not to wait till then and have my own comments, see if I can ruffle some feathers. But anyways, also they had sham titrations in the placebo arm so that people will not know they're on placebo. You have to act completely the same. Imagine giving people a placebo gel for 48 months. And they think they're getting the real thing. So that's one of those things about doing a study. When you put somebody on placebo and you're following for this many months, you have to act the same way you act with the treatment arm. Anyway, so this is one of the tables. I'm sorry, so busy. I've just pulled it from the study, but just wanted to make sure you just saw this is the testosterone arm, the placebo arm, and these are the adverse events associated with testosterone administration. And you see the p-value, significance value. There's obviously cardiac disorders, 0.006, and then there is the strongest of all of the p-values is cardiovascular related events. There was a difference there. All right. And the adverse events, as I said, could be edema, palpitations, AFIB, etc. So it's not heart attacks per se, otherwise the study would not have concluded that testosterone was safe cardiovascularly. So this is a more detailed table on adverse events, investigator reported, meaning the doctors that were seeing these patients. So the arrhythmias, non-fatal arrhythmia warranting intervention, meaning they caught arrhythmias in these patients and they had to intervene, is 0.01. So that definitely is a big difference. 134 in the testosterone group, 87 in the placebo. Atrial fibrillation, AFib, a little bit, 0.02, 91 to 63. The acute injury, 60 to 40. This is when, and we need to discuss eventually in another lecture about kidney, because really this is surprising, although most of these patients had either high blood pressure, where high BMIs, and they may have come in with some kidney dysfunction. So I'm not 100% sure of what the explanation is. It's only 0.04. It's not as strong as these two. And urinary retention, which is not uncommon, water retention in people, especially older men, taking testosterone. So 50 to 34, 0.08. Okay, so there is the congestive heart failure, no significance. Hyperplasia, prostate inflammation, no difference. Diabetes incidence, no difference. Ischemic attack, transient, no difference. So a lot of the things obviously have no difference between testosterone and placebo. So there are questions now. There are questions that remain. At least these are questions I generated, so people may disagree with me. But the remaining questions I need to look at is, would testosterone injections have a more significant negative effect on hypertension and arrhythmias in older men than testosterone gels and creams? Because all the studies, the TOM, the Transverse, most studies look at using androgel because it is the most commonly prescribed testosterone prescription. But not very few people, I don't know of any studies, large studies, looking at testosterone injections. And testosterone injections, at least in my world on ExcelMale.com, are the number one choice for most guys. It's not only they're popular, but they're low cost. Men tend to feel better injecting once or twice a week with insulin syringe. Yes, we have more side effects with injections. Hematocrit, the red blood cells go up probably faster and higher than androgel or any of the gels or creams. But testosterone injections are probably as popular as gels in the United States. Although in my world, on ExcelMale.com, on Facebook groups that I have there, is mostly injections. I do injections. I've tried every product, but I still prefer injections over creams and gels, etc. So I'd like to see whether or not we could do a study comparing a gel with injections, 100 milligrams a week of testosterone, CPA, or enanthate, and look at this man for at least a year, okay? Because most of the side effects really occur in the first 6 months anyways. And what is the role of increased hematocrit in fatal and non-fatal cardiovascular events? Nobody's ever looked at this with men. Basically, this question is related to just testosterone replacement. Men on testosterone replacement, either through the creams, gels, or injections, nobody has done a study on increased hematocrit and whether or not that's linked to fatal or non-fatal cardiovascular events. Only Dr. Amasami has shown some data, which is very encouraging, and he actually agrees that the higher the hematocrit, over 52, the higher the chances for fatal and non-fatal cardiovascular events. But we need more data. The third question, should older men with hypertension or AFib given testosterone be monitored more closely? You know, I think that's pretty obvious from these two studies. We need to look at this man, especially older. And what's older? Over 45? I'm 64. So, and I do have hypertension that is being treated. Hypertension since I was in my teens. I don't have AFib, but this particular subset of men over 45, high blood pressure at baseline, or AFib, should probably be monitored closely, very closely, especially in the first 6 months. There's water retention that happens. Blood pressure can go up even under treatment, and an AFib can get worse. The fourth and last is the observed increased incidence of non-fatal cardiovascular events in the two T-gel studies, TOM and Transverse. Is it caused by stimulatory, neurological, or increased blood viscosity because of TRT? Would love to see people discussing this. I may have a round table discussion. I'd like to see a neurologist talk about it. Obviously a hematologist for the blood viscosity, and somebody that can actually address why AFib, palpitations are increased in older men compared to placebo. We have two studies now that are indicating that. But as I said, I still think testosterone is safe when properly monitored. When you do the right blood work, hematocrit, especially blood pressure, HDL can go down with testosterone. But those are the three biggest factors that can increase, in my point of view, cardiovascular events. Anyways, please subscribe to my ExcelMale YouTube channel. I appreciate it. It really means a lot. Like the video if you can. Register on ExcelMale.com. That's where a lot of the new data is being posted daily by a lot of the members there. There's some urologists and some doctors there too. And you can get a lot of information from really experts, guys that have been on testosterone forever. It's a 14-year-old website. And you can buy lab tests online in the United States without a doctor's visit on my company, discounterlabs.com. I appreciate your listening and stay tuned for more videos from ExcelMale.com. Thank you.